Good afternoon, everyone. First of all, I would like to thank AIOC for this opportunity to be part of this subspecialty capsule. So my topic is role of posterior segment OCT in glaucoma. So OCT is a subjective and quantitative evaluation of the neural structures that are affected in glaucoma, that is the macula, the RNFL and the optic nerve head. Previously, time domain OCT scans had an axial resolution of around 10 micrometer, but in SD OCT it has become almost 5 micrometer with better resolution. So SD OCT increased reproducibility, accuracy and improves scan density, and it also reduces the artifacts and the scan acquisition time. So I had this case in my OPD where I could see a patient with having some inferior rim thinning, as can be seen in this. And there was also a broad RNFL defect. So I did an HVF for this patient, but as you can see that the HVF was almost normal. Though OCT was also done, and then finally it showed some inferior thinning, which can be seen in the sector analysis, and also in the macular analysis we can see some areas of ganglion cell thinning. So a diagnosis of glaucoma, we have to remember that it often precedes the vision loss. The standard automated perimetry is used for diagnosis, staging and monitoring, but it is only likely to detect once the RGCs are lost up to 40%. So visual field testing is often variable and it requires repeated testing. So SD OCT is the most commonly used, and there are Cirrus, Spectralis and RTQ, the main machines that are being used. This table shows the difference between the three machines. I'm not going into details due to lack of time. So what are the OCT parameters that we have to look for in a patient? So it's like peripapillary RNFL, the macular parameters and the optic nerve head parameter. So the SD OCT RNFL thickness, we can see the spectralis image. It represents the ganglion cell axons which enter the disc. The loss of RNFL can be seen in the red field photos, but it is quantified with OCT. It's having good diagnostic accuracy. It quantifies the severity stages and differentiates normal from glaucoma in early stages. So this is the Cirrus HD OCT and optic nerve head analysis report. So first is the key parameters in the table that is marked as 1 in the slide, and then there is a retinal nerve layer thickness map, which is a topographical display of RNFL, and the hourglass shape of yellow and red colors is supposed to be normal. Then we have the thickness map, the deviation map, the NRR thickness, the RNFL thickness profile and average in global and sector thicknesses, which all can be seen. Color coding, we all know green is normal, yellow is borderline and red is abnormal. This is the optic nerve head analysis. It is based on patient's age and the disc size, but we don't go in details in this because the disc size varies between the population. Also, there is torsion, tilt, and peripapillary atrophy. So, what are the RNFL parameters for diagnosis? It is the average circumpapillary RNFL thickness and the inferior sector RNFL thickness, which has having the best diagnostic accuracy. Next is the superior quadrant thickness values. And when we compare both the eyes, the inter-eye difference, if it's more than 9 micrometer, this also suggests an RNFL thinning and early damage. Now we have to keep in mind the artifacts. There can be something like segmentation errors when there is inaccurate delineation of the anterior and the posterior RNFL boundaries. So false decrease can be because of media opacities, cataracts and vitreous debris, and green disease can happen when there's false increase, can be because of myelinated nerve fibers, epiretinal membrane and swelling of the optic nerve head. So more artifacts, this scan shows a decentration. So some of the areas more commonly seen in the myopic eyes, they will present with red, and this is also known as the red disease. So once the scan is repeated with proper centration, the defect corrects. Next, moving to the evaluation of the macular region. So, glaucomatous damage of the macula is difficult to detect on automated perimetry. It's often missed in evaluation of OCT when you're just looking at the circumpapillary RNFL. So, why should we study the macula? Because it has the maximum quantity of the RGCs, almost 50%. Then, unlike the optic nerve and peripapillary region, the macula is comparatively uniform in the patients and the measurements are more repeatable. So in healthy individuals, there is greater or larger superior-inferior asymmetry between the patient and and also in all individuals. And there is also less impact of blood vessels. So in macular area compared with the RNFL. So what are the diagnostic and scanning protocols? First, we look at the cirrus. It's like they're measuring the GC-IPL, the ganglion cell layer, and the IPL. The spectralis has the posterior pole asymmetry analysis, and the RTView has GC-IPL along with the RNFL also. So here we can see an image of the macular analysis, the ganglion cell, and generally it will have an uniform oval appearance if it is a normal eye. But in cases of glaucomatous damage, the hallmark is a loss infratemporal, as we can see in the picture. This is correlating with the deviation map, which is showing inferior thinning and also in the sectors in the right eye. So this is known as the squeaky sign, and this horizontal point is that we can see is the horizontal raphe. So generally, as we can see in this, we can see that there is inferior temporal thinning, which is correlating with the red areas on the sector analysis in both the eyes. And this is the hallmark, which is also correlated with the visual field, which shows a superior defect. So what can be the artifacts in the macular scan? There can be segmentation errors, decentration, or values below 40. And of course, in patients having ARMD, ERM, CME, macular thickness analysis should not be done. So next we move on to detecting progression. So for assessing progression, we have to keep in mind some things like normal attrition, the RNFL attrition, and the other things like thinning due to normal aging, the floor effect, the thinning suggestive of glaucoma progression both globally and within a sector, and correlation of RNFL loss with the visual field loss. So RNFL thinning in normal healthy eyes will have around minus 0.48 micrometer per year. This is seen in the cirrus machine. And in glaucoma progressors, this value can increase up to minus 0.98. And also similar values are shown in spectralis. We should keep in mind the floor effect, which means that the RNFL never goes to zero. That is happening because of Muller cells, astroglia, microglia, and the blood vessels, which do not degenerate completely. Hence, we can see that all the areas over here are red marked, but none of the values are going beyond, going lower than 40. So the floor effect is also shown over here in the various machines, and then we cannot, progression can still occur, but we cannot depend on this. We have to go for a macular OCT or HPF 10-2. So progression analysis can be event-based or trend-based. It measures the difference between baseline. Event-based measures the difference between baseline and the current value. Decrease more than 5 micrometer is suspicion, and if it's around 7 to 8 micrometer, it is definitely suggestive of progression. In a trend-based analysis, we just monitor the slope of the RNFL thickness over time. So this is the GPA printout. It's divided into 4 parts, and I'll go part by part to explain. So the first is the deviation map. It shows change that are statistically significant. It is seen as areas marked in orange, and then subsequently it is shown as marked in red. These graphs show the average RNFL thickness. Here also we can see that the first average superior and inferior. The first significant change is shown as orange and dot, and then the subsequent changes are shown in red. This RNFL thickness profile compares the current visit, that is a C, with B1 and B2, and here we can clearly see that there is some thinning in the inferior zone in the profile. So the GP analysis is a summary of RNFL and optic nerve head summary parameters, and we see that the first significant change is marked as orange, and then the subsequent ones are in red. So average, RNFL, inferior, superior, all are showing thinning. So progression monitoring with macular OCT, we have to remember that in the normal values around 82. Now these are just guidelines I'm giving. They're not absolute, but you have to use them to assess the progression in patient. So supranasal part is the thickest, and the macular GC-IPL will decrease at the rate of around 0.31. That is the normal attrition with aging. And in early glaucoma it reduces to around 75. In moderate it goes up to 64, and then in advanced it may drop down to 55. So if the change is more than 4 micrometer, then it is suggestive of progression. So difference in machines we have to keep in mind. If we use RTView, it generally gives us hither value. So if we use it to assess progression, we get false data. To summarize, OCT is a powerful objective structural assessment tool that can greatly assist in clinicians in diagnosing and managing glaucoma, and monitoring progression by OCT has also is a good quantitative and reliable tool. We should always use it with the clinical evaluation and visual field testing. In early glaucoma, OCT of RNFL and macula is important. and we should always watch out for the acquisition errors and artifacts. Thank you for your kind attention.
When the higher false positive rates with the structural test, how do we differentiate prepigmented glaucoma and red disease?
Through the overall evaluation, so we should not miss the basic findings. We should do a proper disc evaluation, a proper perimetry, and then correlate that with your OCT findings. Then we can avoid making mistakes with red disease.
Thank you, ma'am. I would like to ask, with the upcoming machine learning strategies and artificial intelligence, will it minimize the role of glaucomatologists or will it add value to the practice? Sir, can you please answer the question?
Well, if you look at all the AI things that have come out so far, they have come out for the easy stuff. They have come out to detect diabetic retinopathy, which is there or not there. Any of us saying you can do it. So machines also do that very well. The moment you say glaucoma, the big problem with this, and we are working with 2-3 groups on it, is defining what is actually disease. We are ourselves not sure of how to define disease. I don't think a machine is going to do much better.